Arroyo, I am going to talk about balancing the risks and benefits of dual platelet inhibition. Definition. Cardiovascular and cerebrovascular events commonly arise from arteriosclerotic plaque rupture that produces platelet activation, thrombus formation, and production of downflow to the brakes or heart.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
Application in medicine. The prevention of cardiovascular events in patients with prior heart attack is using ticagrelor compared with placebo on a background of aspirin thrombolysis in myocardial infarction trial. Provide insight into this balance in high-risk patients with a previous myocardial infarction. Pros and cons. Pros. Dual antiplatelet therapy is recommended for 1 year after an acute coronary syndrome, but the effect on longer-term therapy is not clear. Cons. Concerns exist regarding the balance between reducing the risk of cardiovascular events and the risk of bleeding complications, because bleeding complications are linked to adverse outcomes in patients with an acute coronary syndrome.
Hey, this is Yogesh Reddy from AHA 2014. I'm here with Dr. Mori, who was the PI for the DAP trial, and she's going to give us the scoop on this trial. Dr. Mori, if you don't mind telling us, what were the aims and design of the trial?
Sure. Well, the study was designed in order to see how patients with coronary stents should be treated beyond 1 year, especially because we knew that there's some risk of stent thrombosis and, more importantly, a risk of recurrent myocardial infarction in the late future.
Excellent. And what were the results of the trial? What did you find?
So we enrolled 26,000 patients worldwide, and we randomized patients both with drug-eluting stents and bare metal stents to either continued thienopyridine plus aspirin versus aspirin alone. And the drugs that could have been used were clopidogrel or prasugrel. And there were multiple different stent types, including 50% of the stents, drug-eluting stents, were everolimus-eluting stents, so modern-day stents, so very relevant to current practice. And what we found was that in the patients who continued thienopyridine beyond 1 year, out to 30 months, that there was a very significant reduction in stent thrombosis, but more importantly, in myocardial infarction. So the rate of myocardial infarction was cut in half, and stent thrombosis was reduced to 1/3 of what it would have been without that in the patients that were on placebo.
So We have a lot of trials now telling us about the data with 6 months, 12 months, and now this trial with extended follow-up for 30 months. So which patients do you think for the fellows in training, who needs to be treated for 6 months, who needs to be treated for 12, and who needs to be treated for longer?
Yeah, so there is a lot of information about both these drugs and stents over the long term. There are patients that couldn't be enrolled in our trial because they had either had a heart attack during the first 12 months, after their stent procedure. And
Use unplug in Ecuador. In Ecuador, the dual plating in the myocardial infarction after patching a coronary stent and prevention of secondary post-infarction.
Every year, millions of patients worldwide receive coronary artery stents for the treatment of ischemic heart disease. To prevent stent thrombosis after treatment with a drug-eluting stent, dual antiplatelet therapy with a platelet P2Y12 receptor inhibitor plus aspirin is recommended for 6 months to 1 year. The risks and benefits of treatment beyond 1 year have remained uncertain. The recently completed DAPT study randomized 10,000 patients who had received an FDA-approved drug-eluting stent, had already completed 1 year of treatment with dual antiplatelet therapy without having ischemic events, repeat revascularizations, or major bleeding, and had shown a high degree of compliance with that year of therapy. The patients were randomized to receive an additional 18 months of either continued dual antiplatelet therapy with aspirin plus a thienopyridine, either clopidogrel or prasugrel, or with aspirin alone. The co-primary endpoints were the incidence of stent thrombosis and a composite of death, MI, or stroke. As compared with aspirin alone, dual antiplatelet therapy resulted in a 1% absolute risk reduction, a 71% relative risk reduction in in-stent thrombosis, and a 1.6% in major adverse cardiac and cerebrovascular events. The rate of moderate or severe bleeding was higher in the dual antiplatelet group. At the 33-month follow-up, all-cause mortality was 2.3% in the thienopyridine arm, as compared with 1.8% in the placebo arm. This appeared to be driven by a higher rate of non-cardiovascular death that was accounted for by differences in major trauma associated with bleeding and in cancer-related death. The central conclusions of the DAPT study were that dual antiplatelet therapy continued for an additional 18 months, reduced the risk of in-stent thrombosis and major adverse cardiac and cerebrovascular events, increased the risk of moderate or severe bleeding, and increased non-cardiovascular mortality. While it doesn't offer an easy answer, this much-awaited trial adds important data to inform individualized decisions about the optimal duration of dual antiplatelet therapy.
In conclusion, concern exists regarding the balance between reducing the rise of cardiovascular events and the risk of bleeding complications because bleeding complications are linked to adverse outcomes in patients with an acute coronary syndrome. Thank you.